rice bodies because they just lie loose within the joint space, and this is known as rice bodies. So in the X-ray itself, you can see plenty of loose bodies, and it differs from osteoarthritis by the number of intra-articular loose bodies. Even in osteoarthritis, we are seeing osteophytes. They will also be seen within the joint space, but they will be large, irregular, whereas these rice bodies tend to be multiple and variable in size, and they have a very, very smooth surface. So usually they present with pain, effusion, and mainly large joint involvement will be there, and they can enlarge and occupy the entire joint space, and they can also involve the adjacent structures. Sometimes they can even reattach to the joint and can be either primary or secondary. So you can see the synovial lining, nice thinned out lining of the synovium, and beneath that you can see plenty of lobules of mature cartilage. So this is a classical appearance you can see under microscopy. So in primary synovial chondromatosis, it occurs in the 3rd to 5th decade and in an otherwise normal joint. Many a times it tends to be a monoarticular involvement in primary synovial chondromatosis. Whereas in secondary, usually it will be in elderly age group and in a background of arthritis. So whether it can be rheumatoid arthritis or any other inflammatory arthritis, tuberculosis, in any of these secondary inflammatory arthritis especially, you can see secondary synovial chondromatosis. So multiple joints can also be involved and numerous loose bodies can be present. So microscopically, either it can be focal or diffuse involvement of the entire joint. You may see villous hyperplasia, but synovial site hyperplasia is variable. You may see sometimes very much thinned out synovial lining. Sometimes if it is very newly forming, you can also see synovial reactive hyperplasia. Then chondroid bodies and islands can be there with central ossification sometimes. So you can see sometimes entire thing can undergo osteoid formation. You can see plenty of inflammatory cells surrounding this, and the entire body has undergone osteoid differentiation. So here also you can see so much of bone-like appearance. So this is synovial osteochondromatosis. What are the complications probably? Why should we know about this entity? Because there can be a transformation to chondrosarcoma in these conditions. Very rare, but there are documented cases where there can be transformation. And this irritation can also lead to secondary osteoarthritis. Another is the possibilities of recurrence. So even if you just remove the loose body, sometimes they can recur. So if there are only the loose bodies present, you can simply remove, or if it is a diffuse involvement, then it requires synovectomy. So what is the differential diagnosis of primary synovial chondromatosis? That means if you really want to call it primary synovial chondromatosis, you have to exclude all these other categories. That means the secondary osteochondromatosis, where it can be due to the degenerative change or an inflammatory process. Pigmented villonodular synovitis, where again you can see chondroid metaplasia, or synovial hemangioma, lipomatosis. In all these conditions, you can see chondroid metaplasia. So we have to be ruling out all these conditions before wording it as a primary synovial chondromatosis. Then it can also be a synovial chondrosarcoma. Synovial chondrosarcoma, if you see, it will be a soft tissue mass, and there will be definitely extension beyond the joint, and there will be presence of metastasis. This I will tell you once again what are the differences and how to go about. Then you have to differentiate it also from the siderotic synovitis, where you can see the pigments due to hemophilia and more amount of degenerative changes with chondroid metaplasia. Sometimes it can mimic the tumoral calcinosis, where you can see so much of the calcified and ossified structures, which are also tethered to the subcutaneous tissue. So sometimes, very rarely, there are reported cases of synovial chondromatosis transforming to chondrosarcoma. How do we know it is not a primary chondrosarcoma and it is a transformation? One is you have to have a histologic diagnosis of chondromatosis, which has to be established prior to the diagnosis of chondrosarcoma. That means there should be a prior diagnosis of chondromatosis, or you can see both the lesions seen in the same anatomic site. So when you are receiving the biopsy of the synovial tissue, in one area you will see chondromatosis, in some other areas you will see the chondrosarcoma transformation. Or in the same resected specimen, you can see the lesion, both the lesions together, either in the same anatomic site or in the same tissue. And if there is a chondrosarcoma transformation, the most frequent presentations are progression of symptoms, quick local recurrences, and muscle invasion. So usually clinically itself, you may be able to identify that there is something malignant transformation going on. And there are some other non-specific changes where you can see periarticular cortical erosion. Because this is non-specific, why we say is, this can also be seen in synovial chondromatosis when it is secondary, especially when it is rheumatoid arthritis or other systemic immune-mediated disease associated. You can also see periarticular cortical erosion. And extracapsular extension can also be seen in synovial chondromatosis. That is why we can mistake it for a tumoral calcinosis also. Then you can see metaplastic chondroid features. So these are non-specific changes, but sudden increase in size can be an indicator of a transformation, not a slow progression, but sudden increase in the size may be an indicator for this transformation. So we have to be careful in looking into the biopsy if at all we are seeing the chondroid metaplasia. So we have to see whether there is a chondromatosis of a primary or secondary type, or there is some other lesion which is giving rise to this chondromatosis, or whether there is a transformation to chondrosarcoma. So all these we have to notice if there is a chondroid metaplasia or islands of cartilage seen in a synovial biopsy. Anyone can tell whatever is this condition? There is a synovial lining and you are seeing, what is this? This is fat tissue. Okay, so this is synovial lipomatosis. So what is this condition? This is also known as lipoma arborescens or Hoffa disease, or you also know it as villus lipomatous proliferation of the synovium. So this actually tells what it is. Villus proliferation is there and it has so much of lipomatous component. So it is a rare tumor-like lesion, and you tend to see pain, swelling and effusion. So multiple times you can see the recurrent effusion. Why there is pain? Because of the compression effect. And it can be secondary to trauma, viral infection or other degenerative processes. Some authors have also suggested inappropriate fat metabolism can give rise to synovial lipomatosis. Now, there is also a proper tumor, lipoma. How do you differentiate the synovial lipoma versus lipomatosis? So synovial lipoma is a de novo, it's a benign tumor, and it can also occur intra-articular, and many a times it can present with log knee. That means you can see the lipoma impinged between the articular surfaces. So it can give rise to pain once again. So it will be similar in presentation. But what are the other differences we can look into? One is lipoma is a tumor and it has a solitary presentation usually within the synovium. So it will have a smooth contour, and as such, anyway, because it is a lipoma, you will see yellow color, and many a times it will be encapsulated. So it will be a very encapsulated, circumscribed, smooth tumor, and there won't be any inflammation around the fat cells. So usually the treatment is excision of this lipoma. Whereas lipomatosis will involve multiple papillary fronts. That means there is so much of fat deposition within the connective tissue. It is not a true tumor. So since the connective tissue is having in different amount of fat deposition, you will see different variable sized papillary fronts. So there is going to be villus proliferation. This will also look yellow because it is made up of fat tissue. And you will see a hyperplastic synovial lining, and there is going to be minimal inflammation or fibrosis because many times it is of a secondary nature and it occurs secondary to some degenerative or an inflammatory process. So you can see the inflammation, fatty change and the fibrosis, which is an indicator of a stepwise progress of a disease. And it requires synovectomy because it tends to involve diffusely this joint. So you can see the synovial lining proliferation. So you can see this villus fronts. So multiple villus projections and inflammation and these fat globules in between this. So here once again you can see villus proliferation. So in some areas there is flattening of the lining where there is so much of deposition. In other areas you see synovial lining cell hyperplasia. And you can see there is this fat deposition, irregular amount of fat deposition. It is not capsulated like a tumor. Then next, coming to the entity of synovial amyloidosis, you can see different patterns of synovial amyloidosis. One is amyloid arthropathy, or it can be a component of primary amyloidosis, or it can be a secondary amyloidosis following an inflammatory or immune mediated process. So this amyloid arthropathy is one of the presentations where you can see large deposits of amyloid material. Many times it will be monoarticular and presents with joint stiffness, and it results in a non-inflammatory effusion. Actually, some authors have also mentioned that there can be this amyloid material within the synovial fluid. So you can see some cloudy presence of cloudy structures within the synovial fluid, and it can be once again stained and seen under polarized light, and you can demonstrate amyloid even in the synovial fluid. So many authors have documented only a non-inflammatory effusion, and it can present with bone erosion, and most common presentation will be carpal tunnel syndrome. So here you will see tumefaction in the surface synovial lining, and basal wall is not much involved. So this differentiated from the primary amyloidosis. So in primary amyloidosis, most often you see the amyloid deposition around the blood vessels, and it will be in multiple focus. Whereas here you will see the tumor-like mass of amyloid within, in between, just beneath the synovial lining, and vessel wall will not be much involved. And there is not going to be any acute or chronic inflammation. Sometimes it can be associated with skin nodules also. So you can see big mass of amyloid deposit, and these are all only areas of hemorrhage, whereas you don't see any inflammation. Okay, so this is a classical case of amyloid. This person actually, he presented with a joint stiffness. This was an elderly patient. He was 60 years old. He presented with joint stiffness, and when they did the biopsy, this amyloid, the synovial fluid was only showing non-specific findings. There was no amyloid material, we couldn't make out. But in the biopsy, there was amyloid deposit just beneath the synovial lining, and there was no inflammation. And it was just elevating the synovial lining. You can see that there is no chondroid material. It is not a cartilage. It is simply the amyloid without any cellularity, and you are not seeing any inflammatory component associated. And it is just beneath the synovial, thinned out synovial lining. So primary amyloidosis, it is usually associated with, as you all know, either with multiple myeloma or Waldenström macroglobulinemia. So you will see it by the clinical presentation itself. It will be the complete history, and the clinical examination is mandatory to rule out the primary amyloidosis. And in secondary amyloidosis, as you all know, tuberculosis, rheumatoid arthritis, gout, or osteo, any inflammatory process, so it can result in secondary amyloid deposits. What is this? I think everyone will know this. This is, anyone has responded?
Not yet, ma'am.
No, not yet.
Oh, I thought it will be a very easy one.
No, we got response, gout.
Yes, excellent. So most of you would have seen this. So it is a case of gout. So what is a gouty synovitis? You will see milky or chalky white synovial fluid. Even from the synovial fluid you can make out, and it is due to the monosodium urate crystals which are getting deposited, and it can also present with suppurative lesion, or it can present with granulomatous lesion. Both are known, and it can also involve bone, joint, soft tissue, or even the subcutaneous plane. And you can see the osteolytic disruption of subchondral bone also. So you can see in this particular case, there are the gout crystals which are deposited here, surrounded by a granulomatous inflammation. Here, sometimes it can undergo secondary chondroid and osteoid metaplasia also, and some cases can also undergo amyloid deposit. In this particular case, it was going on to form multiple areas of calcification and ossification. So here you can see the gout crystal surrounded by a suppurative reaction. So these monosodium urate crystals, they are needle-shaped crystals. Usually we demonstrate it using a polarizer, and they are dissolving in water-based solutions. So usually the alcoholic fixators are preferred, and they are also can be visualized in thick unstained sections. So you have to simply put the cover slip on the section, unstained section, and see under polarizer. And sometimes you can also stain it with non-aqueous alcoholic eosin stain, and you can demonstrate the negative birefringence for this monosodium urate crystals. Now, pseudo-gout usually will be either in the articular or meniscal cartilage, and only by histopathology we cannot differentiate the pseudo-gout crystals. Usually they are rhomboid or diamond shaped crystals, so only the polarizer can differentiate gout from pseudo-gout. And even biochemical markers can be useful. Both can undergo chondroid and osteoid metaplasia. So the crystals here are calcium pyrophosphate crystals, and many a times they can be associated with any of these changes, either thyroid disorders or parathyroid disorders, hypercalcemia, hemochromatosis, ochronosis, and even systemic amyloidosis can present with pseudo-gout-like changes. Hemophilia and drug-induced also can be associated with pseudo-gout changes. What is this? I think it is easily identifiable by the color. Any responses?
Not yet, ma'am. Ochronosis. Yes, we
Yes,
got.
exactly. Yes. So this is ochronosis. From the color itself, you can make out. It's a very classical case of ochronosis. This was a 17-year-old boy. Actually, even clinically, they diagnosed it as ochronosis because this boy was having typical presentation of urine turning to a very dark color on standing. And this boy was having subcutaneous nodules, multiple joint involvement. So this was a clinical diagnosis itself, and they sent the biopsy for only confirmation. So ochronosis can either be an endogenous or exogenous pigment. And if it is endogenous, it is an autosomal recessive condition and it occurs in a younger age group. Whereas exogenous can either be due to any of these drug-induced reaction. So here you can see ochre colored pigment, and many a times you can see the deposits in the cartilage, bone or skin. Sometimes you can also see in heart, blood vessels, sclera, or even in the respiratory tract. And alkaptonuria, when it is present in the urine, and the urine becomes black when left standing. So this is a very classical presentation if it is seen. So once again, you can see the villus proliferation. Here you can nicely see so many villi are present. You can sometimes see synovial hyperplasia, the lining hyperplasia, or even flattening of the lining. So it depends on the chronicity of the lesion. If there is so much of this pigmentation, it is going and ulcerating the lining, you won't see any hyperplasia in that region. But if it is an early lesion, then you will see a reactive synoviocyte proliferation. So you can see villus proliferation, which is very characteristic, and these pigments, which are very typical of ochronosis. So once again, you can see even increased vascularity can be a reactive change here. Sometimes in the initial stages, you may see inflammations, and it can be either because of, it can either be a epithelial granuloma or a histiocytic granuloma, or even foreign body giant cells can be seen because it is a foreign material. But if it is a later stage, you can simply see a pauci-inflammatory change, and it can also present with fibrosis. So once again, you can see the synoviocytes and the pigment. So this everyone know. I think I will require 5 more minutes. I hope you don't mind it. Shall I take?
Good, ma'am.
So this is, I think all of you will have encountered this condition. This is?
PVNS. They have written PV.
Okay, are you seeing any pigment here? Only giant cells and so much of fibrosis is there. This is a case of giant cell tumor of tendon shape. So how to differentiate these two entities? They are only the both spectrum of the same disease. So this is a localized tenosynovial giant cell tumor, and it is that means it is localized, and it is benign neoplasm, very commonly seen in women or young and middle-aged women, and frequently seen in hands and fingers. Here you can see a circumscribed lesion with lobulated pattern and small stromal mononuclear cells surrounded by foamy histiocytes, osteoclast-like giant cells. Hemosiderin-laden macrophages also can be seen here, and mainly you will see bands of fibroblasts and hyalinization. Because of these bands of fibroblasts and hyalinization, you tend to see the lobulated pattern. So IHC can also be done. Usually we don't require high IHC for the diagnosis. So clusterin can be positive in the mononuclear stromal cells. Desmin can be either positive or negative. And these are the other markers you can do for the tumor. But usually we don't require an IHC for this. And why we now call it as a benign tumor? Previously it was considered as a tumor-like lesion, but now we call it a benign tumor because we can identify CSF1 translocation, and even if there is no translocation identified also, you can see the CSF1 mRNA and protein expression. And the tendon sheath fibromas are closely related to this condition. One main problem is there can be local recurrences if it is not excised properly, and there can be very rare malignant transformations which are documented. So whenever there is a malignant transformation, first thing you see is lack of giant cells, increased mitosis and nuclear hyperplasia. So if you get a giant cell tumor of tendon sheath, look for these findings. If there are very few giant cells and mitotic activity is very high, then you have to warn the clinician to closely follow up the patient. So it will be very circumscribed. You can see a nice band, but there is no villous proliferation. And you can see the bands of fibrosis, the stromal cells, giant cells. And these foamy cells can be present. It can be variable in number. Some areas it can be in lobules. Some places it can be only seen in very few small clusters. So these giant cells are very classical. So this is the entity what you thought earlier. Here you can see pigment, villous proliferation and a nodular elevation. So this is pigmented villonodular synovitis, or we also know it as diffuse tenosynovial giant cell tumor, because usually it occurs as a diffuse presentation and it is unlike the localized presentation of the giant cell tumor of tendon sheath. Okay, so this name is very justified. So many a times nowadays they are using this terminology as diffuse tenosynovial giant cell tumor. And now it is once again put under the category of tumor, not as a tumor-like lesion, because we see the clonality and the expression of this translocation. So it can either be mono or polyarticular. It can also be intra or extra-articular, usually in young age, and it is a benign tumor. Once again, you see the gene translocation of CSF1. That is why we just see that these two conditions are only the two spectrum of the same entity. That is a localized form, this is a diffuse form. And you can see some other chromosomal aberrations also. These are all under study. So once again, you see all these findings. We have already seen this. So you can see this villous proliferation, hemosiderin, and the foamy cells. You can see ulceration of the synovial lining. This was the photograph I had shown earlier. Villous proliferation. It is very characteristic, very irregular. And you can see sheets of foamy cells, hemosiderin-laden macrophages, so many foamy cells, and giant cells, plenty of osteoclast-like giant cells, and hemosiderin. So this is a classical case of diffuse tenosynovial giant cell tumor. So that is a basic difference. That is a localized form. This is diffuse and more amount of pigmentation, and it is a diffuse involvement and giving rise to multiple joint involvement many a times. So you can see so much of fresh hemorrhage as well as hemosiderin. What is this entity? You can see plenty of blood vessels just beneath the synovial lining, and it is more or less like a circumscribed lesion. So this is nothing but a synovial hemangioma. So this usually occurs in young adults, usually in male, can occur in major joint like knee, elbow, or it can even occur in fingers, confined to the intra-articular synovium. It doesn't erode the bone, or it doesn't go beyond the articular synovium. And most frequently you encounter cavernous hemangiomas in this spectrum. So you can see there can be villous proliferation, and you can see the circumscribed tumor composed of large dilated cavernous vascular spaces with extravasation of RBCs, no inflammation. That is one main thing. There is no inflammation at all. So you can see there can be numerous channels, cavernous spaces, and surrounded by this stromal component, no inflammation. And this is the final one. What is this? Any idea? There is synovial villus proliferation, synovial cells are present, and there are these deposits. What are these deposits? This was a patient who was already having carcinoma breast. So she was having infiltrating duct carcinoma treated, and later on, after 7 years, she presented with joint swelling and pain, and it was a hemorrhagic fluid, synovial fluid. And when they did the biopsy, there were this metastasis within the synovium. So you can see synovial metastasis, and here you can see this tumor cells with the comedo pattern of necrosis, typically as you see in the carcinoma breast. So this can happen, so we have to see carefully. So what are the take-home messages from here? So histopathology needs to be correlated with clinical presentation. This may sound like a cliche, but actually this is the truth. We cannot simply see a biopsy and diagnose something only based on the biopsy findings. We have to clinically correlate it, and we have to see that the secondary changes are very common. Already you have seen that chondrite metaplasia, lipomatosis, so many things are happening. Amyloid, all these can either be primary or it can be secondary. So these secondary changes are very common and they can be similar to many entities. So once you look into these secondary changes, do not stop only with that. Even neutrophils can be deceptive in a synovium. So you have to see carefully what are the other findings, and we have to correlate clinically and with the ancillary studies. Then only we can come to a conclusion. And always look for any foreign body, other changes, and we have to analyze the entire morphological spectrum to arrive at the diagnosis. So this is the ultimate thing we have to take care, as we do for any other biopsy as such. But in synovium, we have to be extra careful because there are so many different lesions which can present with similar secondary changes. So the entire morphological changes have to be considered along with the clinical presentation, and if needed, culture and immunological markers. Thank you. Any questions?
Thank you, ma'am. Thank you for an explicit and an interesting session on synovial biopsies. Indeed, synovial biopsies are seldom spoken in many forums. You had very much enlightened about this topic. If there are any questions, you can delegates can post in the chat box. I can read out for the speaker, or else you can unmute and ask the speaker, express your queries to the speaker.
Thank you, ma'am. It was very informative, elaborate, and excellent presentation, especially for pathologists to diagnose synovial biopsy interpretation. Thank you, ma'am.
Thank you, ma'am. Thank you, Dr. Venkat and Shamira. Any other queries also, please raise. I hope it is a pre-lunch session, so everyone is hungry, so no doubts.
There are no any questions, ma'am, queries. So shall we conclude the session?
Yes, sure.
Okay, thank you all. Thank you for, we had very good presentations today. Thank you for the delegates for joining us today. Please join us tomorrow also. Tomorrow we have very interesting talks. One is on the pathology of bladder tumors by Dr. Santosh Menon, and the second following it is interpretation of small bowel biopsies, small bowel pathology and malabsorption syndromes by Dr. Prasenjit Das. Thank you one and all.
Thank you. Join us too.